Okie dokes. Welcome everyone to tonight's Fertility Network UK webinar on Unexplained Fertility. My name is Bethan and I work for Fertility Network UK, providing support to anyone that's on a fertility journey. Just to let you know then, this session is being recorded. You'll be able to watch it back. We'll share it on our YouTube channel. And to let you know as well, to reassure you, we do only record the speakers, so just myself and Sean. Please ask any questions you want, and if you pop them in the Q&A channel, we'll get through as many as we can before the webinar ends at 9 p.m. And again, for anonymity, I will ask those questions to Sean. So without further ado, then let's begin tonight's session on Unexplained Infertility. I'm absolutely delighted to be joined by Sean Watermeyer, who is a consultant in obstetrics and gynaecology in the Royal Glamorgan Hospital in South Wales, and he also works at the Wales Fertility Institute. Welcome, Sean.
Thank you very much indeed, Beth. So guys, starting again then, Beth's given me the title of Unexplained Infertility, and by its very definition, this is going to be quite difficult because it's unexplained, but I will do my best and answer your questions to the best of my ability. So I thought we'd just start with some basics. Fertility issues. What's interesting is that anything up to 1 in 6 to 7 couples need help to conceive, and of course that doesn't count our same-sex couples and single females who also need help. So this is a shed load of people going forward. The definition of infertility is that if you've been trying to conceive with regular intercourse for 12 to 18 months with no success, that is deemed that there is either infertility or subfertility. I wanted just to take you through, though, the fact that if you take 100 fit women who are 25 years old or younger trying to conceive, approximately 60 of those 100 women would have conceived after 6 months and 85 would have conceived after 12 months. So for that age group, you've got about an 85% conception rate in the 12 months. If you contrast that with women about 10 years older, so women aged between 35 and 37 years of age, 85% would have conceived after 2 years of trying. And this would indicate that age really matters. What's interesting with this is that certainly one of the criteria in terms of trying to explain unexplained is and can be sometimes age, as we will see later on in the presentation. But it's also true that it's not just whether or not women get pregnant, it's also whether or not they take a baby home. And there is a difference between that. And I also wanted to take the opportunity to bring up the fact that clearly the older you are, the greater your risk of miscarriage. And these are just some approximate miscarriage rates depending on age. And you can see if you're in your 20s, approximate miscarriage rate is about 10%. And all the way up to when a woman is 45 or more, they go up to anything up to 60%, which is a huge, huge problem going forward in terms of age. So what other evidence is there for the importance of age? And I'm going to talk a little bit about sperm quality going forward. Because of course, this does constitute one of the things that needs to be talked about in unexplained infertility. So I'm referring now to a Human Fertilization and Embryology and Authority report with regard to IVF cycles going forward. And I'm talking about a 2018 report where they looked at the overall birth rate per embryo transferred, was at the highest it's ever been at 23%. Now, things are better since then, but at 2018, 23%, having increased from 15% in 2009. But when they looked at those success rates, the birth rates varied by family type. And comparing patients using their own eggs, they found that the highest birth rates were recorded for patients in female same-sex relationships at 31%, followed by patients in heterosexual relationships at 23%, followed by single patients who have the lowest birth rates at 17% per embryo transferred. So you can see in bold down there, as birth rates steadily decrease with age, the low birth rates for single patients likely relates to their higher average age of 39. So those women in heterosexual relationships and same-sex relationships had an average age of 35 as opposed to 39. But you can see what a difference that made in terms of the rates. What else was interesting, looking at that 2018 report, was that patients in female same-sex and heterosexual relationships both had average ages of 35, as I've already said, but the birth rates were 31% and 23% respectively. So why? Well, certainly it was felt that some of the difference in birth rates may be because of the use of sperm donors by female same-sex couples. Why is that important? Because donor sperm is typically from younger men who are aged 29 years old on average and generally of good quality, whereas male partners were older, 37 years of age on average, and of course some of them may have fertility. So age and sperm quality matter, particularly when you're talking about unexplained. And I will talk a little bit more about sperm quality and semen analysis a little bit later because it is so very important. I wanted then just to touch on some basics in infertility. We've already alluded to the fact that no conception after 12 to 18 months of regular intercourse. But I wanted to just take you through a woman's cycle such that if you've got a patient or a woman who's got a 28-day cycle, ordinarily she will ovulate 14 days before she menstruates. So if you've got a 28-day cycle, you're going to ovulate on day 14. Likewise, if you've got a 30-day cycle, you're going to ovulate 14 days before you ovulate, so that's day 16, and a 32-day cycle, day 18. Now, it's also important to say that an egg will last about 24 hours in the female reproductive system, and sperm will last anything up to 5 or 6 days. So if a couple have intercourse every 2 to 3 days from about day 10 to about day 18, it's going to be very difficult to miss that time of ovulation. When we look at basic investigations, though, and someone asked specifically for what basic investigations to rule out particular abnormalities. Ordinarily, to see if a woman ovulates, we will check a day 21, 23, and sometimes I do a day 25 progesterone. I'm going to go back a slide. So progesterone is essentially a blood test. Oh, now I'm going to go back a one. If we look at a woman ovulating, as the follicle releases its egg, all right, it produces something called a corpus luteum, and that corpus luteum produces progesterone. And that progesterone is maximally produced 7 days after ovulation. So you can see, looking at this, in a woman with a 28-day cycle, she will ovulate on day 14, and the progesterone will be maximally elevated on day 21. Hence, you do a 21-day progesterone. If that is elevated, it is likely then that you have ovulated. Likewise, if you've got a woman who's got a 30-day cycle, she will ovulate on day 16, which means her day 23 progesterone will be elevated, and so on. So sometimes what I find, particularly when I see patients in practice, is that they've had a day 21 progesterone done, told they're not ovulating, but in fact they've got a 30 or 31-day cycle, which means they'd miss it. But in any case, that's one of the ways that you tell whether or not a woman is ovulating. And certainly in a woman who's got a 28 to 30-day cycle, it is likely that she is ovulating on a regular basis. The next thing to tell or to look for is whether or not the tubes, the fallopian tubes, are patent or open. Because clearly if there's a blockage, then egg and sperm don't meet and pregnancy doesn't ensue. One of the ways we do that is with something called an HSG or hysterosalpingogram. And this is essentially a little catheter that fits into the cervix. You squirt some radio-opaque dye into the uterine cavity, and actually you take an X-ray, you can see it going through the fallopian tubes and out of the ends of them. And now I've got some diagrams of that I'll show you in a little while. To ascertain whether or not then you've got a normal uterine cavity and normal ovaries, you can do an ultrasound scan of the pelvis, which I'm sure you're all familiar with. And actually the ultrasound is quite useful as well because it looks at the morphology of your ovaries, whether or not you've got polycystic ovaries, and that would indicate whether or not there's a chance of anovulation. The other way you can look to tell whether or not the cavity is normal is to do a hysteroscopy, which is a little fiber optic camera that goes through the cervix into the uterus, and you have a good look. And I have to say, sometimes some women will have an ultrasound scan and be told that the cavity is normal, but actually that isn't necessarily the case. To know absolutely for sure that the cavity is normal, you would need a hysteroscopy. The next thing on the list for female patients is, have you got adequate ovarian reserve? And in order to determine this, we do a blood test called an AMH, or anti-Müllerian hormone. You can get something called an antral follicle count. That's looking at the number of little, what we call primordial follicles on ultrasound, and that gives you an idea. And you can do a blood test called an FSH, or follicle stimulating hormone. So we know as a woman gets closer to menopause, her estrogen levels drop, which is essentially why she needs HRT. The brain picks up that the estrogen levels are dropping and tells the ovaries to push out more. And it does that by pushing up your FSH. So the higher your FSH, the closer to menopause you become. So it's a blood test that we frequently do together with an AMH and an antral follicle count on ultrasound. And then for the blokes amongst us, for him, it's just the normal semen analysis. But there is a fair bit to say about that and what constitutes normal, as you'll see in a while. So if all those investigations then are normal, then by definition, if that woman is not managing to conceive, she has unexplained infertility. But of course, that doesn't take into account the age for him and actually, I beg your pardon, the age for her and actually the age for him, and by necessity, egg and sperm quality. So this is taken from my little book, Infertility, IVF and Miscarriage, the second edition. And essentially, it's reasons for infertility. So going round here, you can see if you've got poor sperm quality or indeed a count, if you've got no ovulation or absent ovaries, if you've got blocked or absent fallopian tubes, if you've got an absent uterus or an abnormal lining of the womb. So, for example, you've got polyps, which are like little skin tags in the lining of the womb that prevent implantation. Then, by definition, it's going to be one of the reasons or some of the reasons for infertility. But look now to endometriosis, adhesions from inflammation or infection or scar tissue. Now, you won't necessarily see any of that with an ultrasound or with an HSG, or indeed with a hysteroscope. You will only ever see that with a laparoscope. And maybe this is part and parcel of the reason why some patients are given the diagnosis of unexplained infertility that actually later turns out to be endometriosis or adhesions. But I will talk about laparoscopy in a little while when we move on with the talk. So just so that everyone knows, this is an HSG, hysterosalpingogram, and you can see it's a small catheter with a little syringe on the end of it. That catheter is placed in the cervix. Dye that is radio-opaque is squirted into the uterus, comes out through the fallopian tubes, and actually an X-ray is taken. You can see the fluid spilling out of those tubes. This is a hysteroscopy. So now you've got a little fiber optic camera. You can see my drawing of an eyeball at the bottom of it, looking up into the cavity. And there you will see whether or not there are any adhesions or scar tissue or polyps, which of course can then be divided or removed going forward. And then the big one, the laparoscopy. And people sometimes get confused between a hysteroscopy, which is a fiber optic camera into the uterus, and a laparoscopy, which is actually a fiber optic camera that usually goes through your belly button into the peritoneal cavity, and you can look down and look at the tubes and look at the ovaries and look at the uterus. So guys, I wanted then to talk a little bit about sperm, and I wanted to draw your attention to the criteria between the WHO normal values for semen analysis between 2010 and 2021. In other words, between the 5th and 6th edition of what the World Health Organization considers normal or abnormal for sperm analysis. And you can see that looking at the 5th edition, the concentration of sperm that is normal is 15 million of the little guys per mil. Progressive motility essentially talks about how well they move, and normal forms, of which you see on the top table, 4% are only needed to be for that man to be normal. That means 96%, according to that table, 96% of abnormal forms is still normal. Now, if you look at that and compare it to the most recent edition from 2021, you can see that normal sperm concentration is actually 20 million sperm per mil. And progressive motility, how well they move, is 50%, not 32%. And normal forms, actually to be normal, absolutely normal according to the WHO criteria, you need 14% of the sperm to be normal in order for that semen analysis to be normal. And so I'm also drawing your attention to the fact then that a lot of the stuff that went on in the 5th edition, in other words, 15 million per mil sperm concentration, 32% progressive motility and 4% normal forms, actually fits into the borderline as opposed to the normal with regard to the new edition. Now, I also note that many clinics will continue to use the 2010 5th edition. And of course, this makes a big difference because if the semen analysis is actually not quite as good as it could be, if it's borderline, that may be your answer in order to determine what is going on with regard to unexplained subfertility or infertility. So now I'm going to refer you to UpToDate. UpToDate is a brilliant website that looks at all the current literature, data, trials, and summarizes them. And I use this frequently to update myself with regard to what's going on both in gynecology, obstetrics, and indeed fertility. And certainly what they say is that it's relatively simple to identify the cause of infertility in women who, for example, don't ovulate, or whose tubes are blocked, or men with quite severe semen abnormalities. And they go on to say that this accounts for about 3/4 of couples. Infertility in the remaining couples, they say, is likely to be due to endometriosis, which of course you will only find out if you have a laparoscopy, or other miscellaneous factors, which they include there, a cervical factor. So sometimes people talk about the fact that cervical mucus may be hostile to sperm. There may be an immunological factor. Uterine synecdoche are essentially talking about adhesions within the endometrial, the uterine cavity, and then truly unexplained. So they go on to talk about other possible etiologies, and they essentially talk about subtle changes in follicle development, in ovulation, in the luteal phase. So, sometimes I see people having extra progesterone in the luteal phase to try and beef that up. The male partner semen analysis, now I've already alluded to this, shows sperm concentration and motility at the lower end of the normal range. That may make a difference. And I've already established with you and shown you the difference between donor sperm in women having same-sex IVF as opposed to heterosexual couples. Implantation failure, subtle cervical factors, problems with sperm and egg transport. So they go on to say that all these things put together may be part and parcel of it, but it is likely to be the presence of multiple factors, including female partner over the age of 35 with diminished ovarian reserve and male partner with potential low normal semen parameters. What was interesting, they also talk about undiagnosed celiac disease, which, as you know, is a problem with allergy to some foods. So, IVF cycles in the context of unexplained infertility. This I thought was quite interesting because if you look at couples with unexplained infertility who are treated with IVF and you compare them with couples with tubal factor infertility, what they show is that there is reduced egg fertilization and embryo cleavage rates in those couples with unexplained. That having been said, the rates of live birth per transfer are equivalent for both groups, but of course you've got to get to transfer. They further go on to say that couples with unexplained infertility also had a higher rate of complete fertilization failure when treated with IVF than couples with tubal factor. So that's 6 versus 3%. So in this sense, IVF is almost a diagnostic procedure as well as a therapeutic one. What about endometrial receptivity? So defective endometrium, the lining of the womb, being receptive to the embryo going into it, is is thought to prevent normal attachment or invasion or implantation of the blastocyst or day 5 embryo. And that may account for some cases of unexplained infertility and indeed some people say for recurrent pregnancy loss. But the trouble is there are no biomarkers that have been validated for clinical diagnosis. There is, and I will point this out, there is something called an ERA, an endometrial receptor assay, and this involves taking a biopsy from the lining of the womb during a natural or a medicated cycle. In other words, you're having medication in an IUI or IVF cycle, analysing it genetically to determine whether or not that endometrial lining is pre-receptive, receptive, or post-receptive for embryo implantation. And you can then time when you do your subsequent treatment with regard to timing it to the receptivity in any subsequent cycle. I will say, though, that that is HFEA red lighted. In other words, it really doesn't help for the majority of couples going through it. So, what to do? Lifestyle changes, timed intercourse, and then and actually sometimes timed intercourse and ongoing waiting, but going through timed intercourse can have its advantages, and I'll talk about that a little bit later. Then you move on sequentially to treatments requiring proportionally greater resources. So clomiphene or Clomid, and some people use letrozole, although it's not licensed in the UK, plus intrauterine insemination. So Clomid, as probably everybody knows on this call, is used for ovulation induction. And the reason then it's thought it may help is because instead of just one follicle producing one egg, you may get a couple of follicles producing a couple of eggs. But what is interesting is that in the case of patients with unexplained infertility, it does not work if you use it by itself. It only works if you use it with intrauterine insemination. And of course, intrauterine insemination is introducing the sperm much higher up in the cavity, bypassing any hostility that is potentially there in the cervix. And you'll remember we talked about the potential of cervical hostility to sperm. Moving up then, you can use gonadotrophins, so the little FSH injections plus IUI, and the reason this is going to be ever so slightly more successful is because you're going to be producing not one or two, but sometimes three follicles or eggs. You then move up to IVF, and that approach should be individualized. And generally what up-to-date state is that in general, if a specific fertility treatment doesn't result in pregnancy after sort of 3 or 4 cycles, then you should move on to alternative and ongoing treatments. So stimulated IUI or IVF, we talked about clomiphene or Clomid with IUI or letrozole IUI. And of course, if that's not working 3 to 4 cycles, proceed to IVF. Now, this is quite encouraging. Certainly, looking at the 2022 up to date, they're talking about IVF, the intervention that results in the highest per cycle pregnancy rate in the shortest time interval, with up to 40% of cycles resulting in a live birth. But of course, it is the most intrusive and it is the most expensive going forward, unless you are getting it on the NHS. I put in this as well. This is again from my infertility, IVF, and miscarriage book, and again there are approximate take-home baby rates with IUI. Now the graph that's slightly higher is partner IUI, and the one slightly lower is using donor sperm for IUI, and you will see that using the donor sperm is slightly higher. So you're looking at, most of the time I quote anything between 10 and 20% for IUI. But you see, if you're less than 35 years of age, 13% if it's your partner IUI, and 18% if you use donor sperm. And we've talked about the fact that donor sperm are usually younger men and really good quality. So what else? Some clinicians will perform laparoscopy on women with pelvic symptoms if they think there's unexplained infertility. And those symptoms, of course, would be anything from horrendous pain that can be cyclical, suggestive endometriosis, or indeed adhesions. So put a scope in and have a little look and see what's there. What we do know is that if you treat and you find endometriosis, and you treat it, then natural conception rates seem to be improved in terms of your chances of conception. Although there's not a great deal of evidence to suggest that if you treat endometriosis in someone going through IVF, it makes much of a difference. And again, if you are going to treat endometriosis, you have to be a little bit careful, because certainly if you're dividing endometriosis off the ovaries, it can sometimes reduce your ovarian reserve, because by definition, you may be destroying some normal ovarian tissue when you get rid of endometriosis. Up to date also talks about women without pelvic symptoms proceeding with injectable gonadotrophins and are basically ovulation induction. And I've already talked about the fact that you need to do that with intrauterine insemination. Some will perform laparoscopy regardless of whether or not there's any symptoms, rather than just offering gonadotrophins and IUI straight away. But thereafter, they will offer Clomid IUI initiated following your laparoscopy. So again, there's debate about what should be done. Some perform laparoscopy in women with symptoms, some perform laparoscopy on women who don't. Some people go straight to gonadotrophins. Some people start with Clomid or letrozole with IUI. It's hugely variable, which is why a really good chat with your and consultation with your IVF doctor is always a good idea. Now, I talked about the fact that sometimes waiting and continuing with expectant management might be a good idea in some cases. And I need to put this into context. So again, this is from up to date 2022. Overall, 1 to 3% of couples with unexplained infertility followed up prospectively without active treatment become pregnant each month. Well, 1 to 3% is pretty useless. However, the age of the female partner influences that pregnancy rate. So that if you look at expectant management with women who've got unexplained infertility who are older than 37 years of age, the pregnancy rate is likely to be less than 1% per cycle with expectant management. Now, certainly if I was a woman and I was 37 years of age with unexplained, I wouldn't be waiting around. And that's because, of course, the ovarian oocyte pool, the egg pool, declines, and time is starting to tick. But now this is interesting. If you look at randomized trials where they use 6 months of expectant management, see what happened for couples with a good prognosis. In other words, these were young women now, no tubal disease, no sperm problems. These women had a 30 to 40% probability of pregnancy without treatment associated with an ongoing pregnancy rate. So that's comparable then to IUI with gonadotrophin injections over that time. So expectant management might be an option for a couple with unexplained infertility in whom the female partner is less than 32 years of age and there is no immediate concern about egg depletion. Then the inevitable, the lifestyle changes. And this does make a difference. So again, various studies indicate cigarette smoking, abnormal BMI, and excessive caffeine consumption reduce fertility in the female partner and indeed possibly the male partner. And of course, this is going to be in the category of unexplained because it's not something we would test for. We don't ask people how many cups of coffee they have per week, but this is something that may be influencing outcomes. So couples with unexplained should be informed of a possible relationship between cigarette smoking, their infertility, and advised to stop for that reasons. And of course, as well as all the other reasons to stop smoking. I hate to say it, but I always, when I see patients, I say everything between your mouth and your BTM cancer. Why are you doing it? Stop. Female partners should be counseled to try and achieve a BMI between 20 and 27, reduce caffeine intake. So some people don't know this, but caffeine intake to no more than approximately 2 cups of coffee a day, reduce alcohol intake, so 4 standardized drinks per week. I know I sound like a right killjoy. But these changes are useful for enhancing both natural and assisted conception going forward. So finally, some people will ask me about other supplements, and some people ask about something called DHEA, dihydroepiandrosterone, So there was one study found that if you took 25 milligrams 3 times a day of this for 3 months before starting IVF, and this is in patients who are known to have poor ovarian function and have been poor responders in those IVF cycles, or those over 40 years of age, there is some evidence that it will help, and there is some evidence that it reduces chromosomal abnormality. And actually, I've had consultant colleagues who have used DHEA prior to starting their fertility treatments. Coenzyme Q10 is, again, it's not a prescription medication, can be bought over the counter, and that's used by a number of older women undergoing IVF to theoretically improve their egg quality. Impartial. Again, you can get over the internet. This is a nutritional supplement. It can be used by both men and women with fertility issues. And there is some evidence that the micronutrients with Impartial improve live birth rates in couple with a history of infertility. How? By potentially improving egg and sperm quality. And of course, it's very difficult in the test that we do to measure egg and sperm quality, unless patients then undergoing IVF. Okay, what else? Some clinics will use testosterone. And again, there is some evidence that testosterone gel may improve live birth rates in IVF patients if they were previously found to be poor responders. And then other clinics will use everything from steroids, in particular prednisolone, to aspirin, to clexane. So with all these, there is some evidence, but not a huge amount of overwhelming evidence. Otherwise, everybody will be using them all the time. So again, I would advise a good discussion with your IVF doctor about what you can and can't use in terms of what's happened in the past and how you responded in the past to get the best outcome. So to summarize really then, treatment for couples with unexplained, ovulation induction with IUI, IVF, ICSI, and of course there's always the option of using donor eggs and donor sperm. So my final message really is that infertility is very common. If you're young with a normal AMH and all the other parameters are normal, certainly if you're less than 32, as I've already said, it may be worth giving it another 6 months before you start going down assisted reproduction route. Age, I think, is important, and certainly if you can avoid waiting until you're over 35, I would do so. Likewise, if you have been trying for a year or more, get medical help. If there is a family history of early menopause, and this is actually quite important, go get tested, seek medical advice, and if in doubt, there's no reason why you can't have an AMH, an FSH, or indeed an ultrasound scan to ensure normal antral follicle count. Good. Right, guys, there we are. Any questions? I can't promise to answer, but I'll do my best.
Thank you, Sean. If you could stop sharing your screen, that would be fab. And then,
Or share.
I think
Got it.
That's the one. Thank you. So we've had quite a few questions come through. As a reminder, the session ends at 9, so we will get through as many as we can, but apologies for those we might not get to. So the first one then, if you have low progesterone in the luteal phase, does taking progesterone medication help fertility? Also, what does suboptimal ovulation mean?
Right, well, suboptimal ovulation, if we deal with that first, suboptimal ovulation to me means that you're not ovulating on a regular basis every month. And of course, if that's happening, and if a couple is trying to conceive, but I don't know, three months out of 6, the woman is not ovulating at the particular time she thinks, your chance of conception is going to go down quite quickly. So suboptimal means you're not ovulating on a regular basis, on a monthly basis. In terms of the question regarding luteal phase, so there is this ongoing thought that you can have a defective luteal phase and the addition of progesterone will help. I have known anecdotally some patients utilize extra progesterone during that phase, but of course, if you go through any assisted reproduction, I'm sure people who have been through that know all about the cyclogests and the lubions of this world, and taking them for essentially the luteal phase of any cycle going forward. In terms of a woman with unexplained, just using progesterone in a natural cycle, I can't see any reason why not, although certainly to hand, I don't have any good evidence that that will make a difference to your pregnancy rate going forward.
Thank you. The next one then. Following what you've mentioned about cervical hostility, I've seen that cervical stenosis can be a possible factor. I'm starting to notice a pattern in difficulty accessing the area from HSG to embryo transfer. Would it be worthwhile asking for this to be investigated? And if so, how would clinicians tend to investigate for this?
Mm. So cervical stenosis, again, it depends on the degree of cervical stenosis. So sometimes you will, when you scan a woman, you can see fluid within the cavity, and the fluid's in the cavity because nothing is escaping. And sometimes she's got something called a, excuse me, she's got something called a hematometra. In other words, the uterine cavity is full of blood. Why? Because the endometrium is being shed, but none of the blood is coming out. In a woman who has a regular bleed, all right, if blood, generally what I say, if blood can get out, sperm can get in. If you think you've got cervical stenosis, it depends on the degree to which you have. Certainly, if you can get a hysteroscope in, or you can get a catheter in, that should be well enough for the purposes of reproduction.
Thank you. What would you suggest when you've had 2 failed IVF cycles and you've sought a second opinion from a different clinic, and both clinics have said they would not carry out any further testing for endo or adhesions for someone who does suffer from pelvic pain?
Beth, say that again.
What would you suggest when you've had 2 failed IVF cycles and you've sought a second opinion from a different clinic, and both clinics have said they would not carry out any further testing for endo or adhesions, and this is someone who does suffer from pelvic pain?
Yeah. Again, if you remember what we talked about previously, in a woman who has endometriosis that is treated laparoscopically, her chance of natural conception goes up. But there is no evidence that patients who have undergone IVF, or indeed are going to undergo IVF, will have an improvement if you do laparoscopy and excision of endometriosis. So I suspect what those clinics are doing is they're saying, look, if we've undertaken IVF, it hasn't worked. In terms of your fertility, if we now tell you that you've got endometriosis, you've got it. But I can't say that knowing that is going to make any difference to your fertility. If you've got symptoms, on the other hand, and you've got pain, then I don't think it's unreasonable to carry out a laparoscopy to see what's going on and indeed to treat it.
Thank you. Myself and partner, a female same-sex couple, have had 5 egg collections between us. We are using donor sperm. None of our embryos have had normal cleavage. The cells do not divide properly between days 1 to 3, and it results in no blastocysts. Could this be linked to the sperm? We both have normal AMH and good follicle counts. I have Hashimoto's, but other than that, there are no reasons for such poor embryo quality.
The answer is yes, it could be. If it was the same donor sperm used, then that is indeed possible. But that, and I suspect what you'll find is that that's a very, very difficult question to answer, because, and I'm so sorry that you've been through that. But in answer, yes, it may be that sperm is a factor there, for sure, because we know that certainly embryo quality and sometimes even miscarriage rates are going to be affected by sperm quality.
Thank you. What happens when you ovulate on cycle day 30?
I have to say, I think that'd probably be quite unusual. Most of the time, I will look at women who've got anything up to about a 32, 33-day cycle, and if they haven't, if they haven't menstruated by that time, it's likely that during that cycle there's going to be anovulation. To be honest, I've never heard of anyone having a day 30 when they're ovulating. That would be interesting and certainly something I'm not familiar with. So most women will ovulate, and I said before, on day 14 of their cycle. But if they're doing that, most women will have anything between a 28 and a 32-day cycle. If your cycle is longer than that, the chances are that you've got anovulatory cycles going forward.
Thank you. We've had two similar questions then. So one being, my luteal phase is 9 to 10 days long. How much of a problem might this be? And somebody else asked similar, is a 10-day luteal phase okay?
Yes. I mean, so, ordinarily you can see the luteal phase most of the time is about 14 days between ovulation and menstruation. But if that's what it is, I'm afraid there's not a lot that you can do to change that going forward. But again, there is variation in the theme. When I talk about the fact that a woman will ovulate 14 days before she menstruates, some women will ovulate on day 12, some women will ovulate on day 11, others will ovulate on day 15, 16, or 17. So there is going to be variation within a woman's cycle.
Thank you. If there are signs of possible endometriosis on ultrasound, would you advise diagnostic laparoscopy or IUI first line, and why, please?
Again, some of that would depend on the symptoms. So if I see a woman who's got all sorts of symptoms and is in pain, then a lot of the time I would carry out laparoscopy. And we also know that if you carry out laparoscopy, at the same time you can check the tubes. So you can do something called dihydrotubation, which essentially means you put a little catheter into the cervix, you squirt some methylene balloon dye in, and you can see that dye coming through the tubes when you're doing the scope. Anecdotally as well, I've noticed that patients sometimes have a washout of their tubes and they seem to get pregnant thereafter. But I think probably I would be going, if it was symptomatic, I'd be going for the laparoscopy. If I wasn't particularly symptomatic, again, it depends what the ultrasound really said. Because one thing that's for sure, sometimes you'll put a scope in and you will see there are adhesions in and around the ovary that you could not see on ultrasound scan. And in which case, if you're going for IUI, if there are adhesions around the ovary and the egg isn't being released into the tube, you're better off having the laparoscopy first.
Thank you.
Particularly if you've got symptoms. Yes.
Thank you. Is there any evidence to suggest having only one ovary lowers fertility dramatically?
Again, I don't know of any really good double-blind randomized controlled trials looking at that. But certainly theoretically, if you've got one ovary, then there's no reason you can't get pregnant, and that ovary will tend to take over the function of both those ovaries. Anecdotally, again, I would have thought that your ovarian reserve won't be quite as good. But the honest answer to that is I don't think there's any really good data looking at that. Certainly, if you're going for assisted reproduction and you've got two ovaries, you're likely to get more eggs. And so with regard to ART, it's probably going to be slightly better.
Thank you. Can celiac disease impact male fertility?
Don't know. That was easy.
What dose of Q10 would you suggest, please?
Again, usually, again, the answer to that is the recommended dose, because you can get them from all sorts of health food stores. When I recommend this, or in fact, I don't recommend it, guys, and this is really important to say. Generally, what I say is that looking at these nutrients and these add-ons, that if there is no evidence they will do any harm and there is a possibility that they may do some good, I'd use them. But usually you can get different strengths and you can get different manufacturers. And so to come out with any specific dose, look at what the manufacturers suggest.
Thank you. I had an AMH done in 2021 with a result of 35. At the time I was 34. But when I had a recent AMH blood test, the result was 16 at age 36, which seems like a huge drop. Is this something that I should be concerned about?
Um, Again, this is a difficult question to answer because it depends who did it. You get variation depending on the lab. If it was the same laboratory, then it may be something that you need to be a little bit concerned about because clearly the correlation is down. If it was a different laboratory doing it, some people, and I've seen this many times before, one laboratory says one thing, they get something else done a little bit later, and another laboratory says there's a big drop or even an elevation, despite the fact that years have gone by. So if it's the same laboratory, that would be something that you'd have to say, well, why is that? Because it should be reasonably constant. It's not something that goes up and down like your FSH. And it might be worth also looking at other criteria. So other criteria would be, as I said, an antral follicle count with ultrasound scan, and indeed your FSH level, which would indicate whether or not your ovaries are becoming resistant or indeed going up as they do with age towards menopause.
Thank you. Can you explain a little more on testosterone treatment? Is this for women?
Yes. So sometimes people use testosterone gel. Various clinics have used it. I have not used it, but I know that there is some limited evidence for its use going forward in previous poor responders. So if you have never had IVF, I certainly wouldn't be inclined to use it straight away, but there are certainly some clinics that use it. And certainly if you're going to see somebody and you've had poor response to previous cycles, it may be something that's worth considering.
Thank you. Is there any link between high prolactin levels and recurrent miscarriage?
Hmm. The answer to that is that certainly there's evidence that you can get hypothyroidism and thyroid disease that can be linked with it. Certainly there's evidence that your HbA1c, in other words, your risk of diabetes and your predisposition to diabetes can. Hyperprolactinemia can certainly affect your FSH and can affect whether or not you ovulate on a regular basis. I'm not sure there's any great evidence that hyperprolactinemia will affect miscarriage because often people who've got hyperprolactinemia don't get pregnant in the first place if it is markedly elevated because there are problems with ongoing conception before they get there.
Thank you. If you have a clear HSG, does it always mean patent tubes?
There are a couple of things with fallopian tubes. So one is that you can have patent fallopian tubes with your HSG, but it doesn't tell you anything about the function of the tubes. So fallopian tubes themselves will undergo something called peristalsis. They've got little bits of muscle in them that push the fertilized egg along. You actually get conception actually occurs. Egg and sperm meet in the fallopian tubes. They form an embryo, and that embryo is pushed along the tube into the uterine cavity. And that pushing, that peristalsis activity, you can't measure, but you can only measure whether or not the tubes are open. So just because your tubes are open doesn't mean to say that everything is all good and proper with the tubes. And in fact, there are some patients who have had ectopic pregnancies who have known to have open tubes previously. So the answer to that is the chances are if there's no history that's significant, there's no history of pelvic inflammatory disease, the tubes are open, then you're probably okay. But it doesn't tell you it's not the whole story.
Thank you. Do the chances of successful IVF change or reduce in each subsequent cycle?
I can't see any reason why they would. No.
Thank you. Would you advise a laparoscopy if a woman is concerned about scar tissue from having one ovary removed due to an ovarian torsion?
Probably not, because if it was on the contralateral side, so if she had a right ovary removed and she's still got her left ovary intact, most of the time the scarring will be on the contralateral side, so she should be all right. But again, if you've got one ovary there, then certainly it would be sensible to carry out, and there's no reason you can't carry out an HSG, so a pinkogram, to look at the patency of the remaining tube. And if you've got good spill through that and you've got a remaining ovary, then happy days. I would have thought scar tissue or adhesions on the contralateral side, the other side, would be reasonably unlikely.
Thank you. Do fibroids in any way cause infertility?
Crikey, I need to put my thinking cap on now, don't I? There are different sorts of fibroids, and again, it's going to depend where those fibroids are, and it's going to depend on the size of the fibroids. So you can get something called submucous fibroids, and those submucous fibroids sit just underneath the lining of the womb, and it may be they have an effect. You can get something called intramural fibroids, which sit in the body of the uterus. And the main muscle part of the uterus, and you can get something called subserous fibroids, which sit on the outside of the uterus. So the subserous ones probably aren't going to make any difference, again, as long as they're not very, very big. But if you've got a number of small fibroids in the muscle away from the endometrial lining, not impairing the circulation of the endometrial lining, you're probably fine. If you've got submucous fibroids, in other words, these fibroids are indenting the cavity and they're causing distortion of the cavity, then there may be a problem with that in terms of it causing subfertility with regard to implantation problems going forward.
Thank you, Sean. I'm aware of the time, so I'm going to come to the two last questions, which is going to mean quite a few of you don't have your questions answered. So I'm really sorry, but this has obviously proven to be quite a popular session. So the first of the last two then, we've had 3 embryo transfers, all of which have successfully implanted with a positive result, but 2 out of 3 have shortly thereafter resulted in a chemical pregnancy. We had previously administered cyclogest pessaries, but we're about to go through another round. We're thinking of doing Lubion injections instead. Do you think this might help, or is lack of progesterone not usually a cause of this?
No, I think I certainly wouldn't be adverse to that. What we know, and actually for that couple, those people going forward, one thing that is important is that we know that patients, for example, who get spotting in early pregnancy and have had previous miscarriages are actually advised by the NICE, the National Institute for Clinical Excellence, to use progesterone going forward. Now, again, if you use cyclogest, again, you don't know how much of that you're absorbing. And so if you use Lubion, for example, you know you're going to absorb it because it's going under the skin as opposed to just being absorbed through the vaginal mucosa. Equally, there may be, and sometimes people, for example, who get recurrent miscarriage, sometimes there are other things to take into account depending on your age and your background. But certainly, I would have no hesitation if you tried cyclogest before in using Lubion going forward.
Thank you. And the last question then, can you be diagnosed with unexplained infertility without having all of the tests you mentioned?
You certainly can't be diagnosed with unexplained infertility if you haven't had your tubes looked at, if you haven't had a semen analysis, if you haven't looked at whether or not you've got a normal cavity, and whether or not you're ovulating on a regular basis. No. By definition, it needs to be unexplained because all the tests that you've had are negative.
Thank you, Sean. Sean, thank you so much for this evening. Thank you for sharing your expertise in what is clearly an area that lots of us needed a lot more information on. Thank you everyone who's attended and for those asking questions, and huge apologies to those we couldn't get to. But good night, everyone. And Sean, thank you once again.
And guys, good luck in all your endeavors. And certainly, Beth, if I can help in any way, I'm happy to. You guys take care.
Thank you. Good night, everyone.
Good night.